It is my pleasure to introduce today's speaker. Dr. Mickey Kollisch is the pediatric surgeon at SUNY Upstate Medical Center in Syracuse, New York. During her surgical residency, she completed a research fellowship studying protective mechanical ventilation strategies. She used her background in mathematics to study how mechanical ventilation impacts the alveoli and the alveolar duct micromechanics, both in healthy and in injured lungs. In returning to Upstate as faculty, she has joined Professor Gary Neiman as the co-director of the Pulmonary and Critical Care Laboratory and has been continuing her research, now focusing on molecular mediators of lung injury. Well, Mickey, it's now time for you to start your presentation.
Winnie, thank you so much for that incredible introduction, and thank you to Draeger and Winnie and Ed for inviting me to talk here today. It's absolutely my pleasure to be here. Give me 1 second to bring up my screen, make sure that we can get that where it needs to be. Well, I can't say much more after Winnie's wonderful introduction, but I'm going to be talking about APRV, Airway Pressure Release Ventilation in Pediatrics and Neonatology. This is, of course, a topic that's near and dear to my heart, not only as a pediatric surgeon, but as someone who spent a fair bit of time researching lung injury and the mechanism by which mechanical ventilation can not only cause lung injury, but potentially also help to recover the injured lungs. So my disclosures are as follows. I have spoken at conferences that have been sponsored by ICON and by Draeger before. Draeger has been incredibly generous to our lab, and they've supported us with several research grants, and the neonatal study that I'm going to be presenting, they supplied us with pretty much all of the ventilators and equipments that we needed to accommodate it. And I've had a really great and long history with Draeger. Because of their dedication to education, to research, and to really improving patient care. And I think that they go above and beyond in that way. And so again, it's a pleasure to be here today. All right, so most of us know this. The pediatric mechanical ventilation studies that we have are just absolutely disappointing, that we just don't have enough of them, and we don't have enough good mechanical ventilation trials. This table is a nice summary. The second column is the randomized control trials, and the next column are the observational trials. And you can see that there's various different subjects that we're looking at. And if you look at ventilator modes, the only ventilator modes we have randomized control trials in is in the oscillator. And when it comes to setting the ventilator, there are no randomized control trials. And so unfortunately, we have a real paucity of literature and an absence of guidelines when it comes to ventilating our pediatric and neonatal patients. This is sort of telling a similar story. Before I get there, just to kind of think about what pediatric ARDS is and what the scope of the issue is. Pediatric patients with ARDS make up about 1 to 10% of ICU admissions, and the mortality rate is about 24%. This is, of course, a little bit lower than that in our adult patients, more like 35 to 40%. And it's probably because of a little bit of different disease pathology, as well as the absence of some of the comorbidities that many of our adult patients have. So this was a really great paper that looked at all of the different trials, both randomized control and observational trials in pediatrics. The blue dots represent the observational trials, and the red dots and red line represent the randomized control trials. And we're going from 1993 to 2015. And so number one, you can see that there's been an overall decrease in mortality rates. I think we have to interpret this data with a little bit of caution because, of course, the definition of pediatric acute respiratory distress syndrome has become a little bit more refined. And so when we're interpreting these studies, we do have to keep that in mind. The other thing to look at is, number one, there's clearly more blue dots. There's more observational studies than randomized control trials. And the other thing to notice is the size of those bubbles. The size of the bubbles correlate with the number of patients in those studies. And so you can see that really there weren't that many patients in these studies. And this has always been the trend of pediatric mechanical ventilation literature. And if you were to do sort of a similar graph for adults, you'd not only see a ton more both blue and red bubbles. Those bubbles would be enormous because our adult patient populations, we tend to have much larger patient populations. So the problem, as we know, with pediatric mechanical ventilation studies is that, number one, there is a relative infrequency of ARDS as compared with adults, with that sort of 1 to 10%. There tends to be poor recruitment. Enrollment's usually about 60%, and part of the issue is going to be parent refusal. To really get a good, robust study, you need about 12 to 16 participating sites. And of course, it's really difficult to maintain standards across that number of institutions. It should be done over a 4 to 5 year period, not only to collect the number of patients, but also so that you have some longitudinal data. And the last thing is that many studies really require invasive measurements for inclusion, just with the idea of using the PF ratio, the PaO2, and thus blood gases. Now, of course, in pediatrics, we're starting to recognize the value of the SpO2 in guiding ventilation and giving us an indication of how sick our infants are. But when you want to compare that data versus older data, the PF ratio still is considered the gold standard. And so what we do as clinicians, as respiratory therapists, when we're taking care of our patients, is we just end up cherry picking the studies, the techniques that we like from adults and applying them to pediatrics. And the question is whether that's necessarily realistic. If you think about adults in pediatrics, there's certainly a little bit of overlap, especially once you get to some of the older, some of our older pediatric patients or older teens. They're going to have more of an adult physiology. But especially our neonates, they have a very, very different physiology. And so applying the techniques that we use for adults and assuming that they're going to work on neonates is probably not reasonable. And we'll go into a little bit more about neonatal physiology in a minute. I wanted to see the number of articles that are available looking at APRV. And so I looked at APRV in pediatrics and neonatology, and I used every iteration of APRV. And you can just see there's not a lot of data in an APRV. And this is, of course, kind of consistent with the fact that there are not a lot of studies in general. At the end, I'm going to have a link that goes to a site that has all of these articles available for anyone who's interested. Before I go further, of course, I'm calling this APRV, Airway Pressure Release Ventilation, but every vent calls it something a little bit different. I think more so than any other mode, APRV seems to have a whole host of names that it's called, and it really depends on the ventilator that you use at your institution. I think that APRV has probably become the most popularized term, and so a lot of these ventilators are now calling it the mode that they used to, like bivent/APRV or duopaps/APRV, just to try to minimize some of that confusion. A lot of us are probably familiar with the PALIC guidelines. For those of us who aren't, this was a consensus study, and it involved a panel of 27 experts who met over the course of 2 years to develop some sort of taxonomy to define pediatric acute respiratory distress syndrome. And they chose a series of topics. They chose 9 topics, and then they made recommendations based on those topics. They ended up making a total of 151 recommendations. And keep in mind, this was just consensus recommendations. And so, for instance, these are 3 of the topics that they looked at, ventilatory support being, of course, the exciting one for us today. And the number of recommendations you can see are in purple, and the navy represents those recommendations. They said we can't really necessarily make a statement, future research is needed, or there's insufficient evidence. And so you can see that insufficient evidence or future research is quite high and quite variable between 22 and 70%. This is not going to be a popular opinion, but I truly don't love the PALIC guidelines. And it's not that anything is necessarily wrong in it. And I, of course, understand the idea behind it, which is that we need to have some sort of a consensus among physicians. But the problem is that we really should be leaning more towards evidence-based medicine, evidence-based approaches, and using consensus guidelines from a panel of 27 so-called experts is just a little bit too dogmatic. The other problem that I have with it is I do wonder how diverse the panel of experts is. The experts included only pediatric intensivists. It did not include any respiratory therapists. It did not include any physicians of other specialties. And the people who are really for the PALIC study say, well, yeah, that's true, but at least it was a multi-institutional. It was international. And so, they pulled experts from multiple places. And so I went through the whole author list for PALIC just to kind of see where all these authors actually came from. And I would argue this really is not an international diverse consensus. 2/3 of the experts came from the US. And there is a lot of, and I say this in not necessarily a bad way, but there's a little bit of inbreeding when it comes to learning, especially when it comes to critical care. You learn from your mentor who learned from someone else, and you end up learning that there's a network and sort of very few degrees of freedom between one person versus the other. So you end up learning the same thing, and again, kind of learn by dogma more so than evidence. So clearly we need to do a little bit better, we need to learn a little bit more, and we need more studies. But the reason that I really wanted to go into that bit of introduction is just to highlight the need, but also the fact that with APRV, there similarly is not as much evidence as we would like. But my goal today is to talk about the evidence that is there, especially the biomechanics, the reasons why APRV should be working in our patients, the literature that we do have, and then kind of thinking about what we need to be doing moving forward. So this is a very typical APRV waveform screen. We're looking at pressures, flows, and volumes. And I want to start out by talking about pressure. And specifically, not only pressure, but pressure as it relates to time. And this is a video that was taken in our lab by Gary Neiman several years ago. And what you're looking at on the left is a lung that's opening up. It's being exposed to the same constant pressure. On the right, you're seeing that same lung, but now with the microscope directly on top of it. And so all those bubbles that you're seeing are alveoli. And those alveoli are slowly trying to recruit. And you'll see that there's that one open area. And in just a few seconds, you're going to see that alveolus finally starts to fill that. And the important thing to recognize here is that the lung and these alveoli are being exposed to the exact same pressure. The pressure is not changing, it's not being modified. The only thing that's being modified is the time, and the alveoli and the lungs are being exposed to that one pressure over a given period of time. And that's a really important point, because when we're setting our pressure, it's not as important, or it's not only important what pressure we're setting on our patients, but also the degree of time that our patients are being exposed to that pressure. Now there we're looking at alveoli, we're looking at the kind of the peripheral lung, but the other thing we have to think about is that the air that we're putting in through the endotracheal tube also needs to get to the alveoli. They need to get that distal. And so I really love this modeling paper. This was a single network model where they basically take an air finger and then kind of try to map out how long it takes to get to the distal airways. And they sort of mapped in like different compliances to the regions, and so green represents the more compliant open airways, and the purple represents the more narrow and stiff airways. And then again, using this network model, they kind of track this finger and see how long it takes. And again, you're keeping the same pressure, but it takes a fair bit of time to get to the distal alveoli. And so if we were trying to really optimize our open lung approach and make sure that, that we're able to open up those collapsed alveoli and those collapsed airways, time is going to be of critical importance. So on the left, we now have what I would call a quote unquote conventional ventilation waveform. You have a brief inspiratory time and a prolonged expiratory time. On the right, this is a more typical APRV or airway pressure release ventilation waveform. And this is the first time that I'm going to introduce a new term called TCAV, time-controlled adaptive ventilation. When we talk about APRV, APRV is a mode. When you say that you've put someone on APRV, it's the same thing as saying I put someone on ASV, on volume control, and pressure control. It doesn't say anything about the settings. And this is a really important point, because when it comes to setting APRV according to an established method, saying something that you put someone on TCAV would be sort of the equivalent of saying I put this patient on volume control with a low tidal volume. So it gives you an idea of the settings. And so from here on out, when with the studies where we're using that TCAV protocol, I'll use TCAV instead of APRV. Now with APRV set according to the TCAV protocol, you're spending the majority of your ventilator cycle at inspiration, and then you have a brief expiratory phase. That way you minimize derecruitment during that short time, but you're maximizing your inspiratory potential by having a prolonged T-high. So if you look at the box, the area under the curve, you can see that even though the plateau pressures are the same, the plateau pressures are 20 centimeters of water for each, the area under the curve, the degree of pressure the lung is being exposed to, is greater in TCAV without necessarily causing any additional static strain, where the lung is being injuriously inflated and potentially causing overdistension. And so we calculated this out, and ultimately the area under the curve is going to be your integral. And so we term this the pressure time integral. And in this series of studies, we're looking at APRV, which is the solid line. This is going from baseline up until 48 hours or 2 days. And you can see that there's a markedly increased pressure time integral in the APRV group that you don't see in the LTV or low tidal volume group. And that's the big advantage to APRVs. You're able to achieve higher mean airway pressures without actually increasing the degree of static strain. And in this case, this was back when we were using APRV as the title, but these animals are being set with the appropriate TCAV protocol. All right, so how do we set TCAV? So we're going back to this low tidal volume graph. We take the P high, the plateau pressure from the low tidal volume or from the more conventional mode, and you set that as your P high. This is for pediatrics. This is a little bit different than in adults. In adults, you'll usually add on 1 to 2 centimeters of water, but in pediatrics, we try to keep them even. And then the P low we set at 0. And this is something that that's a little bit counterintuitive because we, of course, want to make sure we're not causing any recruitment, derecruitment. Of course, you want to minimize driving pressure. And so if someone sees a P low of 0, then of course you're going to be thinking, oh my gosh, you're going from a plateau pressure of 20 to P low of 0. That means you have a driving pressure of 20. As long as you set your T low appropriately, the lung never has a chance to get to that P low of 0. And there's a reason for not wanting to add on an extra pressure. The most important thing is that T low, that release phase, is the lung's opportunity to finally ventilate, to get rid of CO2. And if you add on a P low, then you're essentially adding on a resistor. So you're preventing some of that ventilation from happening. The other thing is that the shorter your T low is, the longer your T high is, or the more opportunity you have to spend at inspiration. And ideally, you want to spend as little time as possible at expiration to try to minimize the chances of causing more atelectasis or more lung collapse. So the T high we set equal to about 90% of the ventilator cycle. And then the T low is going to be the really important thing. This is the one thing that we really have to modify. And this is when it comes to the TCAV protocol, time controlled. It's because of the importance of time. And time is often something we don't really talk about when it comes to conventional ventilation. The other thing we often don't necessarily pay as much attention to in conventional ventilation are the flow waveforms. And I think this is unfortunate because the flow waveforms really teach us a lot about the patient's underlying lung physiology. If you have a really stiff, resistant lung, then you're going to see that by having a really acute angle in your expiratory waveform. Versus a patient who's obstructed or asthmatic, then you're going to see a potentially very long expiratory waveform. And so you can actually gauge how well the patient's doing and how responsive they are, how much lung recruitment you're achieving just by mapping out those flow curves. Okay, so we've just finished inspiration. We've released our inspiratory phase, and now we have our expiration. So we have PEF, which is our peak expiratory flow, and in this diagram, it represents negative 100 liters per minute. So we can choose when we want to terminate that flow, which is represented by the T low. We can terminate at 25% of the peak expiratory flow. And then on the right, what you're looking at is a false color mapped image of alveoli. So the alveoli are highlighted in yellow, and then all of the collapse, all the remnant that isn't open alveolus is red. And so you can see there's a fair bit of atelectasis if you extend out that T low too long. You can terminate at 50%. You can now see a little bit more alveolar recruitment. Or 75%, you really have a set of nice, open, homogeneous alveoli. And this is really the sweet spot. And 75% termination, that's what represents the TCAV protocol. Okay. So we've talked about some of the mechanics behind APRV in the general settings. Pediatric and neonatology and neonatal settings for APRV are just a little bit different. And so we're going to go through the settings for each. Let's say you're someone who feels really comfortable with APRV, with TCAV, and you say, you know, this patient's intubated. I know it's a safe mode. I know it's an open lung mode, and so I'm going to put this patient on it right away. Then you sort of have to choose your desired plateau pressure, and this is really going to be very much based on judgment. How sick is the patient? Do you think that they can tolerate going up on the P high? And if when in doubt, it's always safe to start a little bit lower because you can always come up a little bit if you're finding that your oxygenation is not where you'd like it to be. So you set at your desired plateau pressure in newly intubated. If you're transitioning from conventional ventilation, as I mentioned, you take the plateau pressure from volume control, or you take the peak airway pressure in pressure control mode. And if you're transitioning from the oscillator, you take the mean airway pressure and you add on about 2 to 4 centimeters of water. In all cases, the P low is set at 0. The T high is usually somewhere about 3 to 5 seconds, which is similar to adults. Adults, you're kind of more towards 3.5 to 5.5 seconds. And then your T low is set somewhere between 0.2 and 0.8 seconds in general. That's more of an average than anything. But of course, the T low is going to be determined by your expiratory flow waveform. And now going into just a couple of the studies that we have. This was a study that came out of CHOP. They just looked at 15 patients, and it was those patients weighing greater than 8 kilograms. They compared SIMV versus APRV. The one thing we have to be very cautious with is that they did not provide any description of ventilator settings. And you have to be wary of that because it's really difficult to compare one thing versus another if you don't know how it was set. And so APRV could have been set in a very different way than TCAV, and so you're not entirely sure what these results mean. The exclusion criteria were all quite reasonable, but what they showed is that the peak inspiratory pressure in APRV was lower significantly as compared with the volume control ventilation mode, and similarly the plateau pressure was also significantly lower in APRV. And so what they concluded is that using APRV in kids with mild to moderate lung disease ended up leading to comparable levels of ventilation oxygenation, but with significantly lower inspiratory peak and plateau pressures. This was another study looking at pediatric acute respiratory distress syndrome from age 1 month to 18 years. And I'm always going to talk about some of the things we have to approach with caution, but a 1 month old is always going to have a very different physiology from an 18-year-old, so we do have to keep that in mind. They defined ARDS based on the PALIC definition, and they chose to take patients who were refractory to conventional low tidal volume ventilation, in other words, persistent plateau pressure greater than 30 or inability to wean the FiO2, and transition them to APRV, set by the looks of it by TCAV standards. So they set the P-low of 0, and they set the T-low to prevent full deflation of the lung. And what they found was that APRV had similar sedation requirements, but an increase in the SpO2 to FiO2 ratio, an increase in mean airway pressure, and a decrease in mean peak pressure. So already seeing fairly consistent results in those studies that we have in APRV. So this study was much anticipated. We were all looking forward to this study. This was really one of the only randomized controlled trials we have, and it looks at APRV in pediatric acute respiratory distress syndrome. And similarly, they looked at kids from 1 month to 12 years, where I would always caution you when you lump a 1 month old in with your adolescent children. ARDS by the Berlin definition over a 2.5 year period. And they terminated the trial after 50% enrollment when the analysis revealed a higher mortality in the intervention arm. So these results were obviously hugely disappointing. But again, it's important to think about what they were doing with the ventilator and what the methods were. So let's look through this. They took the pHi and they set at 1 to 2 centimeters of water above the plateau pressure. I think that's reasonable. We were kind of talking about you kind of set the plateau pressure at about the pHi, but going up by 1 or 2 is probably okay. And then they said if the plateau pressure cannot be reliably determined, and you have to wonder about this because it's pretty hard not to be able to determine the plateau pressure because even an inspiratory hold you'd be able to find it, and so it does make you wonder what the thought was behind that. But they then sort of modified the pHi accordingly. And then they said that the time spent at pHi, the THi was set at 4 seconds. This is a little bit long, especially if you're including 1 month old kids where you're really thinking kind of slightly shorter THis, because kids obviously do have a higher respiratory rate as compared with adults. So the THi was a little bit unusual as well. They set the P-low at 0. They set the T-low in order to terminate the release at 75% of the peak expiratory flow rate, so that's all excellent. And they said the T-low is titrated frequently, and that makes a lot of sense because as the lung gets worse or gets better, the T-low is going to end up needing to change. This is probably the biggest, if I were to say, flaw of the study, which is that they adjusted the pHi to maintain release tidal volumes of 6 to 7 milliliters per kilogram. The one thing we haven't talked about at all when it comes to setting APRV according to the TCAV protocol are tidal volumes. And the reason for that is because we don't set tidal volumes using APRV. Ultimately, when you've set your pHi and your THi, you're allowing the lung to expand as much as it's able to without necessarily enforcing a certain tidal volume. And the idea then is that as the lung slowly recruits, those tidal volumes are going to get bigger because now you have a nice open homogeneous lung across which those larger tidal volumes can be distributed. And so to say that you're going to put these patients on an open lung approach and then to restrict the tidal volumes is absolutely counterintuitive. And I would not be surprised if it wasn't this especially that potentially led to some of the worst outcomes. There was also some thought that there was a lack of stratification, some differences in some of the baseline characteristics. But I think more than anything, this was the biggest thing that made this an APRV study, but not using the TCAV protocol. The only other comment I wanted to make is that they said that they would scale down the P-high if the domes, the diaphragm, were visible below the 9th posterior rib and were flattened. And I actually really like this. I think this makes a lot of sense. If you get a chest x-ray on a kid and you see that the diaphragms are flat, it probably tells you either your P-high or T-high are a little bit too high and that you can probably start scaling back. The last thing we want is to be ventilating our kids close to TLC where they don't feel like they can breathe, because one of the huge advantages to APRV is the fact that you can very comfortably, spontaneously breathe on top of it. So the author of the randomized control trial then later published a review paper, and the conclusion he said was we really need to be careful with APRV, and even went so far as to say that clinicians should avoid the personalized APRV strategy. In that same paper where he made that comment, you can see that he included actually a very nice table. It's a table of essentially all of the APRV articles. You can see N, which is the number of patients in each of the articles, and then some of the major findings in each. And you'll notice that in all of these, that they are all favorable for APRV. It shows that you have lower PIP and plateau pressures, improved oxygenation, prone position is feasible, there's lower sedation requirements, more improved oxygenation, no change in hemodynamics. So I think that the lesson to be learned here is to always be cautious when you're interpreting a study, look at the methods and really see what those settings were that they're using. So I wouldn't necessarily use that study to as evidence to not use APRV, especially by the TCAV protocol in your children. The one thing that people get a little bit nervous about with APRV, which and I understand, is that with all that pressure and especially at a longer time, you have high intrathoracic pressure. And so is there any decrease in venous return? Does it cause any hemodynamic compromise? And there were two studies that looked at both of these questions. And the first one on the top shows that they showed that APRV does not lead to significant differences in hemodynamic parameters. And the hemodynamic parameters that they evaluated were mean arterial blood pressure, central venous blood pressure, and heart rate. And then in the next study, they showed that APRV does not lead to significant difference in blood pressure or urine output. And so from a hemodynamic standpoint, APRV does not really seem to make too much of a difference. I will say that if you are using APRV, or rather the TCAV protocol, late, in other words, a child is quite ill and you're using it more as a rescue mode, you do have to take into account the volume status of the child before you immediately transition to APRV according to the TCAV protocol. You might need to think about gently resuscitating the child as you're going up on the P-high, just so you don't drop the pressure too acutely. They almost need to kind of work their way up and get used to it. And now going into some of the neonatal studies. First of all, I mentioned that neonates are very different from kids and they're very different from adults. And so this is just a slide of looking at the embryology of the human lung in the neonate. And so we're going from the embryonic period to the pseudoglandular, to the canalicular, saccular, and now the alveolar period. The canalicular period is between 16 and 24 weeks. And we're seeing many of our infants being birthed at 24 weeks or younger, 24 weeks, 23 weeks, 22 weeks, even some infants who are a little bit over 21 weeks. And so if you look at the canalicular stage and what that corresponds to in terms of lung development, those are the respiratory bronchioles. In other words, those infants that are being born at 22, 23 weeks that we're mechanically ventilating, we're actually not ventilating the alveoli at all. They don't even have alveoli yet. And so the idea of applying the same respiratory principles that we know in adults to neonates is probably not reasonable. The other thing to keep in mind is that the process of alveolarization actually continues up until, some will say, even up to about 8 years of age. And at birth, you have about 25, maybe up to 50 million alveoli. And that process of alveolarization, you end up with 375 million. So something to keep in mind is, again, as you're thinking about your ventilation strategies. The other thing that's a little bit different in the neonates, especially the preterm neonates, is that they don't have all the same collateral channels that we do as adults. And those collateral channels can exist between the bronchioles, they can exist between the alveoli themselves. Those are very well established. They're called the pores of Kohn. And this is important because if you are giving a tidal volume, if you're giving a pressure to an alveolus and the neighboring alveolus is collapsed, there's an opportunity for that alveolus to open through not only its own small alveolar duct, but also through a neighboring alveolus. And in the neonate, if you don't have those, that means there's really only one opportunity. And so the idea of really making sure that they're seeing enough pressure, and specifically enough pressure over time to open up, becomes even more of critical importance. So though I think, again, this isn't exclusive to APRV. The fact is that we just don't know enough about neonatal mechanical ventilation. But I think that there are certain concepts that we all agree on, if nothing else but by principle. And so some of them, I've listed 5 of them. The first is to try to avoid ventilation within the first critical days of life, and ideally by just initiating non-invasive ventilation like CPAP or even nasal CPAP. The second is that you want to limit oxidative injury by minimizing oxygen requirements. The third is we want to ventilate by an open lung approach, and this will ideally allow for homogeneous and even distribution of tidal volumes. We want to minimize overdistension, and we want to minimize recruitment, derecruitment, or strain. And I think that these are all fairly good general physiologic principles that we can all agree on. And the question is, can we develop a mechanical ventilation protocol that does all that? And I'm going to make the argument that TCAV follows all 5 of those principles. So the first, avoid ventilation. Ideally, we avoid ventilation. We can't always. Some of these babies do need to be intubated, especially our really early preterm infants. But the important thing about TCAV is that it essentially is CPAP. It simply has a release phase. You're ventilating them at a high pressure, and then you're just allowing a brief release in order to allow for ventilation. And so even if they are endotracheally intubated, you're still following those same principles essentially of CPAP. Number 2 is you want to limit oxidative injury by minimizing oxygen requirements. This was one of the animal studies that we did up in the lab, and we're looking at TCAV, which is the black solid line going from baseline up until 48 hours. We're looking at FiO2 on the x-axis, and we're comparing the TCAV protocol to low tidal volume applied late, in other words, after ARDS developed versus early, which is the hashed line. This was the low tidal volume ventilation protocol was established immediately. And you can see in the TCAV group, the FiO2 requirements did not change throughout the study. And these animals tend to get quite sick with both a sepsis and reperfusion injury, both of which often are pretty common in our neonates. And the FiO2 is 21% throughout the entire study, and that was significantly less than the late low tidal volume group and less than the early low tidal volume group. The third principle, ventilating an open lung to allow for homogeneous and even distribution of tidal volumes. So this was actually some unpublished data from one of these studies. And on the very left, we're looking at naive lungs. These are totally healthy animals, no injury at all. And you can see how nice and pink and fluffy and healthy they are. There's absolutely no airway edema. If you look at the TCAV protocol on the very right, you can definitely see there's a little bit of injury. Now, keep in mind, these animals were ventilated for 48 hours after having a 2-hit injury to them, where they usually get very, very sick. And you can see there's just a little bit of basilar atelectasis, and also keep in mind these animals are supine for the full 48 hours. And the airways are also relatively clean. Compare this with the early low tidal volume and especially the late low tidal volume. You see that angry, slapped red, inflamed appearance, and you also see that all that airway edema. So the TCAV protocol maintains these open, healthy, fluffy lungs that have a really good homogeneity. And then number 4, minimizing overdistension. This will also give us an idea of the homogeneity with this study. This was a study where we looked at the alveoli of the lung. We put a microscope directly on the subpleural surface of the lung, and we ventilated the animals with no lung injury. That's represented by the light blue group. And we just wanted to get a sense of the alveolar size distribution. If you have a normal set of lungs that is not injured and that is responding well to mechanical ventilation, you'd expect a normal distribution, just like you have in that blue curve. Then we injured the lungs and tried different mechanical ventilation strategies. I'm only showing one of the graphs, but this is the graph of APRV, where the 75% represents the TCAV group. And actually, you can see that in all of the APRV groups, you maintain that homogeneous distribution of alveoli, even regardless of the T-low. I'll tell you, the expiratory flows do not look the same as this particular one, but this one illustrated the point a little bit better. But the other thing is, as I mentioned, we want to limit overdistension. So if there were a population of really big overdistended fat alveoli that were sort of accommodating larger or injurious tidal volumes because the neighboring alveoli were collapsed, you'd expect either a shift or a skew of that graph, or you'd expect there to be another hump of alveoli that are big and distended, and you don't see that. You see this beautiful normal distribution. And then the last thing, this is true of all mechanical ventilation, you want to minimize the recruitment, derecruitment, minimize the strain, minimize the driving pressure. Those are all sort of synonymous. And this was another study where we used the in vivo microscope and looked at the subpleural alveoli. And again, we just changed the T-lows for APRV, moving up to setting the T-low to be 75% of the peak expiratory flow, in other words, the TCAV protocol. You can see the alveolar tidal volume in blue on the right, and you can see alveolar microstrain in red on the left. And number one, you can see the alveolar tidal volume is incredibly low in the TCAV protocol, as well as the alveolar microstrain. The one thing we don't see here, but it's an important point for this study, is that the tidal volumes in this 75% group, the TCAV group, the tidal volumes were about 11 cc's per kilogram. And so, of course, all of us are thinking, oh my gosh, 11 cc's per kilogram is absolutely injurious. It seems like a terrible idea. But look at the alveolar tidal volumes. These alveoli are hardly moving. And the reason is because there's so many open homogeneous alveoli that they're able to accommodate that tidal volume. And this is why, again, we don't set tidal volumes in the TCAV protocol. The lung itself will inflate if it's able to, or it'll slowly start to nudge open as you're working them out of the lung injury phase. And then going into the settings for neonates, just a little bit different than in the pediatric group. Again, if you have a newly intubated patient, you kind of have to use a little bit of judgment to decide the plateau pressure that you're starting with. And if it's a super preterm infant, then it might be a little bit lower versus a term infant might be a little bit higher, but this is a fairly wide range of about 10 to 25 centimeters of water. When you're transitioning from a conventional ventilation, again, you take the plateau pressure and volume control or the peak airway pressure and pressure control mode. If you have a really sick baby, I have had some babies where we've had to start with the mean airway pressure from the previous mode and just kind of slowly work the way up as you're nudging the lung open. And then if you're transitioning from the oscillator, you again take that mean airway pressure. In pediatrics, it's usually about 2 to 4 centimeters of water that you add on. In the oscillator, you'll just add on about 0 to 2 centimeters of water. And then as we talked about, the P-low is always going to be 0. The T-high is a bit shorter now, and the reason is, as we kind of mentioned, the infants are naturally going to have a higher respiratory rate, and you try to match that to some extent. So the T-high is going to be lower in your babies and your neonates, but your T-low is also going to be lower. And so your ratio of T-high to T-low actually ends up being about the same. I've had some super sick kids who've had a T-high of like 1.5 seconds, and the T-low I think was somewhere around 0.14, 0.16 seconds. And if you think about the ratio of them, it's going to be about 1 to 6, 1 to 7, and that's very similar to what we would see in pediatrics and even adult patients. But again, the nice thing here is, again, not only time control, but also adaptive. We can adapt those times according to what the infant's lungs are telling us they can handle. The one word of caution that I would have with this, especially in the neonates, there are some ventilators that do not accept a T-low of less than 0.2 seconds. And so in your preterm neonates, those ventilators may not work for them. The other word of caution is there are some ventilators that do not go to the 100th of a second, they just go to the 10th of a second. And in a neonate, the difference between 0.18 and 0.2 seconds actually can be a big difference. It could be the difference between you're terminating at 50% versus 75%. So something to be cautious and aware of. This was a small study, it was just 5 infants, and these infants had a combination of ventilator synchrony, inability to wean, refractory hypoxemia. And I like this study because they were preterm, very low birth weight infants. And they showed that these infants tolerated APRV well with no adverse events. In other words, they showed that it was safe. And that's the one thing that we always worry, especially about in our neonates, is with newer techniques, is it safe? And then once we've shown it's safe, now we can show, is it efficacious? Is it better? Is it improving our lung oxygenation? Neonates are particularly challenging, not only in the acute phase, but up to 40% of them will go on to develop bronchopulmonary dysplasia. And if the mechanical ventilation strategies that we're setting, either because of too high pressures or too high oxygen, is contributing to that mortality and morbidity, then that's definitely something that we need to work on improving. So in this trial, they just had a nice summary of some of the adult APRV trials versus the pediatric APRV trials. Notice the y-axis is a little bit different for adult. The y-axis is double that of the pediatric trials, but the trend is similar, which is that there seems to be more trials as time goes on, rather more cumulative trials as time goes on. But the other thing we'll notice, which is what exactly we'd addressed before, which is that there's just as few studies as there are in pediatrics, there's very few randomized control trials, which is the dotted boxes. And then you can see the total N, that's the total number of patients that were recruited into these studies. In the adults, it was just over 1,300, and neonates is just 111. It's always difficult to make recommendations based on just 111 infants and from a whole variety of different studies. And then you can see APRV is gaining acceptance in adults. I found that it's especially gaining more acceptance within surgery patients and trauma patients. APRV, actually I should say TCAV, the use of TCAV, especially in trauma patients with extrapulmonary lung injury, you really see a marked difference. And I think it is slowly starting to catch on a little bit more in some of our medical or pulmonary lung injury patients. But compare this with the pediatric population where the incidence is only about 1.6%. I think we have a little bit of work to go for this to gain a little more acceptance. And the authors kind of concluded the same thing, which is that APRV can certainly be used for a variety of indications, but at this point, most consider it still more of a rescue mode. So the one thing that I wanted to do back when I was a research resident was to try to find some way of demonstrating safety and possibly efficacy in the use of APRV. And that's one way that animal models really can become quite useful. But of course, this required starting out with developing a model of respiratory distress syndrome. And so if you look at just starting out with piglet lung maturation, we had to kind of decide what age pigs we were going to use. And so you can see the days of gestation are on the top in black. A full-term piglet gestation is 115 days versus a human gestation 40 weeks. And then piglets breathe spontaneously right about where humans are at 32 weeks. And then once you get to 98 to 100 days, that's when you start to see deficiencies in surfactant, and just a little bit lower than that, essentially all piglets require mechanical ventilation in order to survive. And so we selected our population at 98 to 99 days, which correlates with about a 25-week human infant. This was an incredibly challenging study, as you can imagine, because not only do these infants have difficulties with oxygenation ventilation, but they are also hemodynamically unstable. They have thermoregulation issues. Their eyelids are actually still fused. But the idea was that if we can find a great way of ventilating these patients, then certainly this is something that would be applicable to our human patients. We instrumented them with umbilical artery and umbilical vein catheters or gastric tubes, just like you would in any neonate. We did do a tracheostomy instead of an endotracheal tube, just because the snouts are a little bit big, and so we wanted to make sure that we didn't accidentally intubate the esophagus. And they were resuscitated, just as you would see in any neonatal intensive care unit with antibiotics. We provided maternal plasma for host immunity, nutritional support, and then fluid as needed. And then we monitored them for 24 hours. And you can see that each individual patient, each individual piglet had its own ventilator, its own hemodynamic monitor, its own fluids. And the most important thing is, of course, these animals were kept very, very comfortable and sedated throughout the entire experiment. Of course, as I mentioned, we always have to talk about the settings. So we compared APRV set according to the TCAV protocol with volume guarantee. We set tidal volumes of 5.5 cc's per kilogram, inspiratory time of 0.3 seconds, a rate of 40 breaths per minute initially, and of course these were all titrated as needed. Started at a PEEP of 4 and FiO2 50%. For TCAV, we started with a pHi of 17 to 21 centimeters of water. We started them on volume guarantee and then used the plateau pressure to guide the pHi, just as we had kind of discussed. The T-high was set at 1.3 seconds, T-low 0.15 seconds, again, titrating as needed, P-low of 0 and FiO2 50%. And then we'll go through some of the results. The plateau pressure was statistically similar between volume guarantee and TCAV. The volume guarantee group is highlighted in blue and the TCAV is in the purple hashed line. And we're going from time 0 to time 24. And all the graphs are going to look similar after this. The FiO2 was higher in the volume guarantee group as compared to the TCAV group, but it did not reach statistical significance. The PF ratio was statistically significantly higher in the TCAV group as compared to the PF ratio, as compared to the volume guarantee group, where the majority of the TCAV group ended up with a mild or no ARDS, and the volume guarantee group ended up with a mild to moderate ARDS. This was where we really saw the biggest difference, was in terms of compliance. You can see that the TCAV group has a markedly improved compliance as compared with volume guarantee. And certainly I'm maybe overinterpreting these results, but this is really what you want to see in your kids who have respiratory distress syndrome, in trying to prevent them from going on to develop chronic lung disease with BPDs. You want to make sure those lungs stay as open as they possibly can. These animals don't really have any alveoli, so you want to make sure that those bronchioles stay open and have the best opportunity of inducing alveolar differentiation. If you look at the gross lungs, volume guarantee is on the left and the TCAV group is on the right. You can see that the TCAV group has these nice, relatively open lungs as compared with the volume guarantee group. And then if you look at the X-rays, you can see a little bit of hazy opacification in the volume guarantee group, and the TCAV group, they're nice and open. The one actually criticism that I have for us is that this was, of course, at necropsy, but or just before necropsy. If we had gotten this X-ray a little bit earlier, we probably would have come down just a little bit on the pHi or the T-high, because again, you can see a little bit of that that diaphragm flattening. And then if you look at histology, the one thing you notice is we really don't have alveoli. We have relatively thick walls, and we don't have any nice skinny alveolar walls with epithelial cells. The control group actually has almost the thickest walls, just because these animals never really had an opportunity to breathe before we euthanized them. The TCAV group has the most open airways as compared with the volume guarantee group, which just has slightly thicker walls between them. And then we looked at cellularity as an idea of to give us an idea of inflammation and how much debris was in the airway. And in the TCAV group, you can see that there's more cellularity as compared with the control group, but it was still significantly less than in the volume guarantee group. And so that was the study, again, that we did several years ago. And I think that we're probably going to reinvigorate that study and possibly looking more towards meconium aspiration syndrome, which is also one of those diseases that can be really severe. And many of those babies end up going on to ECMO. And so I think that also represents a unique population of patients who could benefit from TCAV. So some of the conclusions, and I hope that I timed this well, so we'll have a few minutes at the end for questions. Number one, children are not little adults. They have different physiology. They respond differently to mechanical ventilation, and current pediatric mechanical ventilation practices are nonetheless largely based on adult practices. One of the very common questions I get is, what is the best mechanical ventilation strategy? There is absolutely no best mechanical ventilation strategy. The best mechanical ventilation strategy is one that you feel comfortable using. If you start using mechanical ventilation strategies that you're not comfortable with and end up setting them injuriously, you can actually cause more damage, even with a very, very good mode. And so some future directions, and these are some of the directions that we're working on in the lab. We are working with some bioengineers who have been using math modeling techniques to sort of do deep learning to basically develop some other additional protective mechanical ventilation strategies. In other words, learning from the bits that we know do work and wondering, is there another way, is there alternate ways, or a better way that we could be mechanically ventilating our patients? One of the things that we're working on, this is actually more in the trauma theater patient population, but the idea of training ventilators to dynamically adapt according to the patient lung physiology. I think that machines are going to end up being smart enough, or possibly smarter than us, that they will be able to judge what adjustments could be made based on patient physiology and adapt accordingly. That may or may not happen in our lifetime, but I think that is absolutely going to be something that's going to happen in the future. And then the thing that I'm hoping to be working towards in the next couple of months, this is what Winnie mentioned, is the idea of using mRNA-based diagnostics to not only identify lung injury early, but also to potentially come up with molecular therapeutic options. I would like to thank you all for your attention. And again, thank you so much to Draeger for inviting me to speak at this webinar. For anyone who doesn't think that I went through absolutely every single APRV article that I could find, I put them all on our website. And if you go to this website and click on pediatric APRV articles, you'll find truly every article that I was able to get my hands on. If anyone does find any additional ones, my email address is on the website. Please feel free to email me. And also, please feel free to email with any questions or concerns.